My name is Anthony Asher. I'm a neurosurgeon, and I'm the Vice President of the NeuroPoint Alliance and the Director of the National Neurosurgery Quality and Outcomes Database. I'd like to first differentiate between the method that we use to collect the information and the information in the study itself. First of all, we took our information from a clinical registry. The clinical registry is called the National Neurosurgery Quality and Outcomes Database. A registry is a method to collect information from clinical care regarding the outcomes of patients and the responses to therapies. We use the National Neurosurgery Quality Outcomes Database to specifically look at patients' responses to surgery for lumbar spine disorders. And what we observed is this. First of all, virtually all patients started before surgery with significant baseline disability. Second, regardless of the surgical therapy we employed, regardless of the diagnosis, regardless of the location, patients on average experience significant and sustained improvements in disability. Disability is observed by the physicians, disability is reported by the patients. The second thing that we observed was, of course, some patients didn't improve. And in round numbers, approximately 12% of patients did not experience significant improvements in important patient-reported outcomes such as disability. About 17% of patients stated that they actually would not have had the same surgical procedure performed again. Now, when we started looking at the individual responses to therapy, that's where I think the information became very interesting. On average, again, most patients improve. But if we look at the individual response to therapy, we find tremendous variability in response, which is to say, some patients responded a little, some patients responded a lot. Some patients actually got worse, as I mentioned. But we were more interested, frankly, in the patients that were on the improvement side, because some patients reported a 2% improvement, some patients reported a 50% improvement. And our belief was that if we could somehow dissect out what factors were determining whether a patient had a small or a large response to therapy, we could improve care. We could improve care in a couple different ways. We'd improve care by advising patients who had a high likelihood of having a negative response to therapy that they shouldn't have that surgery. We could perform better resource utilization by using the same information. So in other words, if a physician is armed with that information, he would be better able to withhold a surgical procedure from somebody who, again, had a high likelihood of complication or a high likelihood that they would not improve. So when we looked at the variability, we did it using a method called Univariate Analysis. And this is just a start. But what we did was we asked a simple question. When we look at the individual patient characteristics, such as age or weight, and other factors such as liability status, education, and other things, we asked whether those individual factors could be tied with an association to various outcomes. In other words, did they influence outcomes in any significant way? And what we found was very interesting. A number of factors did seem to influence outcomes in a statistically significant way. We then asked whether or not combinations of those factors would more significantly predict a negative outcome. And in fact, the more of those negative factors a patient possesses, the greater the likelihood that they would not have a significant response to therapy. What we plan to do in the near future is this. We will be looking at something called a multivariate analysis, where we look at the combined contributions of factors to see if we can develop a very, very robust predictive model. That predictive model should, as time goes on, allow us to personalize care such that when a patient comes into the hospital, we can plug their particular demographic information into a patient calculator. We can also look at their diagnosis, and we can furthermore look at the specific procedure that is proposed. With that information, we should be able to calculate to a reasonable level of accuracy that patient's risk of having a complication, their potential of having success or not responding to a therapy. And the surgeons can also use that information, again, to more effectively use their resources appropriately. And the surgeons can use that information to more effectively apply surgical resources. Going forward, we can also use that information for quality improvement at the local level. So right now, a lot of quality programs will look at an individual's performance and then benchmark that against a national average. But there's a problem with that because all practices are different. Some practices have very complex patients, some patients do not. And so in order to do appropriate profiling, appropriate analyses of practice that allows for focused quality improvement, what we really need to do is risk adjust the information, which is to say, again, we need to look at the individual factors that are likely to influence outcomes and then give individuals information that relates to their expected outcomes. If they have their expected outcomes and they compare that to their observed outcomes, they'll be better able to focus their quality improvements going forward. And those quality improvements should be much more specific because they are not going to be benchmarked against, again, a national average that may or may not reflect their particular patient population. The take-home message is this. Patients on average improve significantly after lumbar spine surgery, and that's important. I think we've validated what many of us suspected, which was spine surgery is a very valuable treatment option for patients with medically refractory disorders of the lumbar spine. However, the average is not necessarily what we need to be focusing on. We think a much more sophisticated way of looking at the issue of patient outcomes is to start analyzing outcomes on the individual patient level, and specifically looking at the factors that are likely driving outcomes in various patient populations. If we can do that, we can accomplish three important things. First of all, we'll achieve true patient-centered care. We'll allow patients to make appropriate decisions on their own behalf using the best available information in a very personalized way. Second, we'll allow for better resource utilization because patients and their surgeons will have a much better idea of what therapies are more likely to work. And finally, we'll allow surgeons to participate in much more intelligent quality improvement at the local level because they'll be able to focus their quality improvements on analysis of their expected outcomes versus their observed outcomes, as opposed to national medians or national averages that may or may not reflect their particular patient composition and their particular practice patterns.